Ideas 42 Academy Seminar Series. My name is Mitra Salosel, and I'm the Director of Communications at Ideas 42. And on behalf of all of us on the team, I want to thank you for tuning in to learn more about applying behavioral science to tough social problems. Today, we're joined by one of our academic affiliates, Dr. Alister Martin. He is a practicing emergency physician and former chief resident at the Massachusetts General Hospital. He also serves as faculty at Harvard Medical School in the Center for Social Justice and Health Equity, working at the intersection of public policy and medicine. He's also the founder and executive director at Vote ER, a nonprofit organization aimed at using healthcare settings as a place to help patients register to vote. Today, Alister will discuss findings from research and interventions from a collaboration with Ideas 42 on using behavioral science to address the opioid epidemic. Before I hand it off to Alister, I just want to go over a small logistical matter. For those of you who haven't joined us at previous Academy seminar series, we'll be taking questions through the Zoom Q&A box at the end of the presentation. We'll have about 20 minutes or so. Feel free to drop your questions into the Q&A box as you have them, and we'll answer them live all at once. So as they occur to you, just go ahead and drop them right in there. You can find that Q&A box at the bottom of your screen. All right, without further ado, Alister, over to you.
Thank you very much, Mitra. And it's a real pleasure to be here speaking about some of the most important work I've ever done, to be honest with you. And I could not have done any of it without Ideas 42. So, you know, I mean this when I say this. I know I joke about this a lot, but I am probably the world's #1 biggest Ideas 42 fanboy. And so, you know, really love what you guys do. And I think you guys create so much good in the world, and you should be very proud of that, particularly now. So how did I get into this? It was 2 a.m. on a Friday night in my ER in Boston. This is about 7 years ago now. And I had a young woman who came to the hospital asking for help. She was in her late 20s. And I'll never forget this. I was walking by the waiting room and saw her there with her suitcase and a couple of bags. And in the ER, we are very fond of gallows humor, because you kind of have to have a sense of humor to do the job, honestly. And so what that particular finding is called in the ER is the positive Samsonite sign. When somebody has their luggage in the waiting room, you know you're about to step into a complicated situation. So I asked her to come back, and I hear her story. And she says, "Look, Doc, about 4 to 6 weeks ago, I fell down the stairs at my son's daycare." She was a mom of 2. And I broke my ankle. And I had to have this pretty massive surgery at some other hospital. And they put me on a medication called oxycodone. And everything was fine initially, but then over the course of the next couple of weeks, I realized that I just could not feel normal without this medication. She started taking some leftover pills that her husband had in her kitchen cabinets and in the bathroom. And soon things escalated to the point where she was getting doses from her friends and family. It had gotten so bad that about a week before she saw me in the ER, she actually found a dealer. And you know, she's telling me the story, and she says, "Look, you know, tonight I realized that I didn't want to live this life. This is not who I am. I'm a mom. You know, I wanted, you know, to not have this happen to me." So I texted this guy, this dealer, and I said, "You know, I'm done. Please delete my number. I never want to hear from you again. I'm getting help." And the dealer responded, and I actually remember seeing the text message. You know, "Good luck. Addiction is hard, and I wish you the best." And that's where she thought it was going to end. And that's where I thought it was going to end too, except that about an hour later, she heard a knock at her door. She went downstairs. It was her dealer. And her dealer said, "Look, you know, I know what you said. And also, you know, it's hard being in recovery. And so I want to give you a couple of pills for the road just in case, for free. And she took the pills. Her husband saw this and intervened. And basically they had a long conversation about what was happening. And, they made the decision at that time, it was a Friday night, probably 11 o'clock at that time, to get her help. But there was nowhere else for her to go. So she came to my hospital to see me in the ER. And guys, I was like 6 weeks into being a doctor. I had no idea what to do. But I knew that I needed to help her. So I, heard this whole story and left the room, went to go talk to my attending physician and say, look, we've got this woman here who needs help, and I want to admit her to the hospital. I want to get her into addiction treatment, and I want to help her get her life back. And he said to me, Alister, that's not what we do here. Discharge her. And I remember that walk coming back from where he was sitting, from the desk back to her room. It felt like the longest walk I'd ever taken in my life. The feeling of being, having this identity of who I was as a physician, as a healer, being activated by her and her story, and then telling her that I was going to be able to help her, and then having to come back and say, actually, no, I can't help you. And I think about her a lot, like I hope she did get treatment, and I hope that she did get her life back, but I don't know. Her story is just one of the dozens of stories like her, of patients who I've had to, say no to at the beginning of my career. And over the course of the last 7 years, I've used those stories as fuel to try and create a better world where patients who come to the emergency department for help can actually get that help. And when you ask ER physicians nationally, what's going on with the opioid epidemic? Do you feel like things are getting better? The vast majority say, no, this is not getting any better. In fact, it's probably gotten worse. And when you look at the data with regard to places where healthcare is delivered, the ER has had a disproportionate impact. You see, in the last 10 years, we've had an over 100% increase in ED visits for opioid addiction. We are disproportionately on the hook for taking care of these patients because many of them feel marginalized and don't feel safe or comfortable sharing what they're going through in primary care offices or with their doctors. There's a certain anonymity to going to the emergency department that I think is freeing for some people. And then when you ask ER physicians, okay, so you have patients who come in with addiction, what do? 93% of them say, we do detox and abstinence-based methods. Why is that a problem? It's a problem because detox does not work. You will never see, I promise you, a more straightforward randomized controlled trial result than what I'm showing you right now. This is a randomized controlled trial where they took 2 different groups of patients who were struggling with opiate addiction. One group, they did detox, this thing that 93% of us say that we do, okay? And they compared that to a group that got buprenorphine, which is a medication we're going to talk about. What happened? Remember what I said, you're never going to see a more stark result in any field. The detox group, not only did 0% of them stay in treatment, 20% of them were dead before the treatment was over. 75% in the buprenorphine group stayed in treatment. And so just to talk a little bit about the background of buprenorphine, first of all, it's a partial mu agonist, so you can't get high from buprenorphine if you've got a history of opioid use disorder. It's paired with Narcan, so you can't really misuse it because if you misuse it, it activates the Narcan, the naloxone. And it's been used for over 30 years in the addiction community. It is the gold standard in the addiction community to get people their lives back. We've also got good data on how to use it in the emergency department. This is a study that was done back in 2014 where they randomized patients in the emergency department to get buprenorphine or to not, either via referral or in another group, which is just a brief intervention group. And the bottom line is they followed these people out for a month to see how many of them are still in treatment at 30 days. And again, similar, very clear signal here that putting patients on medication that works helps people get better. So back in 2015, when I had this patient story, this patient who impacted me, the ecosystem was summarized in the following way. The problem was summarized in the following way. Number one, the opioid epidemic was worsening. Number two, treatment options were limited or ineffective. And buprenorphine is effective and was effective, but virtually no ERs were providing buprenorphine. So for us, the solution back in 2015 was to start an MGH-initiated buprenorphine program. At that time, there were no hospitals on the East Coast that had this protocol. There was only one hospital on the West Coast, done by my brother in arms, Andrew Herring, who is just a real incredible advocate for patients and a real change maker. So he and I sort of studied each other's notes to an extent, and really proud of the work that he's been able to do on the West Coast. So what were the challenges? Why couldn't we do this? Like what was stopping us? The first challenge was that we had current federal law that was stopping us. It was a barrier. Behind that challenge was a hidden opportunity, and that was to start the Get Waiver campaign. The second challenge is that we did not have a buprenorphine protocol. And for us, that hidden opportunity was to create one of the first buprenorphine protocols nationwide. And then lastly, changing clinician practice patterns is hard. They say you can't teach an old dog new tricks. Well, try to teach an old physician new treatment protocols. It's nearly impossible. But the hidden opportunity was to leverage behavioral science and work with you all at Ideas 42 to figure out how we could sort of address the action intention gap. So this is the first challenge, current federal law. By the way, this is still law. You have to, in order to prescribe buprenorphine, have take an 8-hour course, and you have to pay a course fee. So this is just giving you an example of how it's ridiculous in 2021. Organizations are still making money off of this. But basically, this is the American Society of Addiction Medicine making money off of getting people their buprenorphine waivers. And so the bottom line is, if you tried to create a system that was more difficult than this to treat patients for opioid addiction, you could not, I promise you. An 8-hour course, and I got to pay how much money? It's ridiculous. So I want you to just guess how many ER physicians had this DEAX waiver. This is back in 2017 when we started. I'll give folks 5 seconds. It's 1%. Middle of the opioid epidemic. Is anyone surprised that we haven't gotten better, that the opioid epidemic has not been impacted in a sort of positive way in the last 3 years? And so the opportunity here was to create the Get Waiver campaign. And so at the heart of the Get Waiver campaign was 2 very fundamental pillars. The first was leveraging political field organizing tactics, and the second was really using tried and true behavioral science interventions to help get our physicians waivered. And so back in 2017, when we started, we have 42 physicians in our ER. Only one of them had a DAX waiver. We recruited a team of designers, behavioral scientists, and public policy students, and we designed and launched a campaign using behavioral science to try and really get to this goal, which was get a critical number of MGH-ED physicians out of that 42 to choose to get waivered without making it mandatory. At the end of the campaign, I'm just going to cut to the chase, we got 95% of the department waivered. About 40 of those folks decided to move forward. How did we do it? So the first question I had to ask myself was, how do I think strategically about segmenting our constituency? How do I let the dominoes fall in such a way that we can sequence this campaign? So we mobilize folks in the most straightforward way possible to get this waiver. Secondly, and that's the political organizing side. Secondly, what are the available nudges, and what are the sort of examples of those nudges that have worked in other settings that I could lift and bring to this work at Get Waiver? So the first thing we did, this is Ideas 42 is not involved in this piece, but I was familiar with the DDTS framework. I'm still learning. But basically first we conducted a bunch of interviews just to understand, what were the concerns, why hadn't people decided to do this previously? And the goal of that was to really try to begin to segment the department, figure out who were the physicians that were in the yes group, who were like, yes, I'm totally going to do this. It's just a matter of like making it easy. Who are the folks that are in the maybe group, and who are the no group? And the goal here was to activate first the yes group, then get them to influence the maybe group, and ignore the no group for now. So really sort of starting first with the yes group, activating them, getting them to get their waivers, and then having them in a peer relational way communicate horizontally so that the maybe group would also come on board. So this is just some archetypes, right? After we did our interviews, we built out these archetypes of who these groups were. And this is kind of the two big groups that came out. The yes group, Maggie is a representative archetype. She's a champion in the making. An opioid use disorder champion in the making. And then you've got Bill, who's skeptical, distracted, but persuadable. So what were the barriers that Maggie had in the yes group? Maggie's barriers were threefold. The first was she had hassle factors that were in her way. Number one, it was difficult to access the course. Number two, she's very busy. So finding a time to schedule this, 8-hour course is kind of, it's a whole day. And number three, there are little things like getting your DEA number or your medical license number, which don't seem like that hard. But for an ER physician who's busy, he's got a bunch of other things going on. I don't know where my medical license number is right now. I probably could find it, but it would take me a solid 9 to 10 minutes. And that might be the thing that differentiates whether or not I even move forward. Number two, social norms. She's asking herself, is it okay to do this, to get this waiver? Why haven't other people done it? Next, she has to create a new habit around this, which is new for her. And she's not had to think much about, this approach of using medication to treat addiction. And then lastly, in terms of her third bucket, education, she just needs to know simple things like, what dose do I start at? What are the sort of pitfalls I need to be watching out for? This is an actual quote from one of our interviews. I'm on board. There's not much you have to do to sell me on this, but the problem is I'm not sure where or even how to access this course or how much this thing costs. Bill, on the other hand, had very different barriers. Number one, he had legal concerns. He wouldn't feel comfortable administering buprenorphine. Bup is the way we refer to it in the hospital, unless he had the waiver backing him up. So the bottom line there is you can give buprenorphine without a waiver in very sort of clear and narrow circumstances. And even if we created clarity around when those circumstances were, he wouldn't want to be involved in that. He felt like he had to get this waiver. Number two, he needed to know what the department's position was on this. He needed some higher level authority figure to say, yes, this is appropriate, and yes, I'm behind this. Social norm barriers, this is in effect another way of saying what I've just said, which is just a lack of a social norm in the department around this. Let's go to the hassle factors. He wasn't interested in doing an 8-hour course at all. And so we had to sort of problem solve around that. And an online version would be doable. There's a program called HealthStream that every physician has to do online. He would sort of, quote unquote, treat it like a HealthStream module. Similar to Maggie, he does not know where his DEA number or medical license is, and it's not always readily accessible. And then lastly, just on the educational side, he doesn't know the data on the efficacy of buprenorphine. He thinks treating someone with by giving them a detox referral is appropriate. But remember that graph. What happens to the ones that we send to detox? And let's just talk about that for 1 second. They die at higher rates because they detoxed, they lose their tolerance, they go back to their community, they have no tolerance anymore, and they use the same amount of opioids, and they overdose. So he is thinking, well, listen, I am treating those folks. I'm getting them to detox, when in fact, it's actually quite harmful. So this is what he says. Look, I probably would click through the course online, but I'm not sure I would do the in-person course. And CMEs, continuing medical education credits. This was something that we hypothesized as an incentive to give to people. He says, look, they're pretty easy for me to come by, so that's not going to motivate me. I guess if it's something that the department is doing and that was made clear from leadership, I'd probably do it. So that gives you a sense of sort of who's in the room and what their barriers were to moving forward. So to summarize, the Yes group had a series of barriers, and the Maybe group had a series of barriers. And we had to figure out, how do we sequence our nudges, our interventions, to first activate the Yes group and unlock them, and then have them do our work for us and bring the Maybe group along. So that was sort of all background information. That was all sort of prep. As Abe Lincoln says, if you give me 9 hours to chop a tree, I spent the first 8 hours sharpening my axe. And so that was sort of how we thought about this. And so we broke the campaign up into 2 phases. Phase 1 was all about cultivating that Yes group, those champions. And then phase 2 was sort of this broader appeal to the entire department through a month that we made out of thin air called Get Waivered Month. Coming back to our toolkit, we're going to do a fly overview of how we use some of these nudges. I think just because of time, it probably doesn't make sense to go too far into this, but the bottom line is, in phase 1, we used a variety of nudges that were really all about, number 1, building the groundwork, doing our initial outreach, getting some data and storytelling, and then getting, most importantly, the funding to cover the cost of this course so that nobody had to pay $200 to do this 8-hour training. And then phase 2 was all about the Get Waivered Month itself. So after we unlocked sort of the Yes group physicians, got a certain number of them waivered, we then used them to then communicate out to the rest of the physician community that Get Waivered Month was here, and that they also had to get their waivers too. And the big group of sort of categories of interventions here were the initial launch, where we did things like having an email come from the vice chair announcing the Get Waivered Month. The vice chair is one of the most important authority figures. Number 2, we highlighted this champion group of initial folks who got their waivers, including the chair of our department, who's the number 1 physician in the department, and about 5 other really important physicians in our department. In terms of meetings, we had faculty-wide meetings and residency-wide meetings where we sort of trotted out this champion group, these five initial physicians who were highly respected, brought them to these meetings, and they talked about their own experience, why they chose to get waivered, and what the process was like. And it was them communicating, not me or not the Get Waivered campaign. And then the last 2 buckets here, in the broader appeal, we just sort of inundated folks with, physical reminders, with posters near their computers in the emergency department, pictures of folks completing their their Get Waivered training. And we even got the local media to come and do a story on them getting this waiver together. So yeah, I'm an example guy, concrete example guy. So I wanted to show you guys some concrete examples of what this looks like. So this is an example of social norm intervention where we had our vice chair sending out an email specifically to one of the department members who's very well regarded. And so this vice chair would, sort of make a direct ask to that one well-regarded member and say, I want you to join me in getting this waiver. And that vice chair did that with 5 other well-regarded department members. Here's another example. We started a social media profile, and every time we had a waiver training session, we took pictures of it, we popularized it, we celebrated it. As I mentioned, we got the local news to come and do a story on it. And so we were kind of demonstrating to folks, hey, not only is this a good thing to do, but we're going to make you doing a good thing observable. Because in medicine, and I think in other sectors, you have to make doing the right thing observable for a certain segment of folks to come along with you. This is another example, a hassle bias example, where we found everyone's DEA numbers and medical license numbers and just gave them to them up in front of before they even signed up for the course, so that everybody had that sort of at their fingertips. Another example here, we built a website which basically made it very clear, here are the 3 steps you need to do to get waivered. Number 1, sign up for this online course. Number 2, send this email. Number 3, here's a pre-written draft that you need to then send to the DEA. And so we kind of made it very straightforward for people to follow these 3 steps. This is probably one of the coolest examples. At the end of every one of these get waivered sessions, we had a pinning ceremony, which sounds cheesy as hell, but it was really, really effective. We had the head of addiction medicine who would literally place a pin on the white coat of a physician who just finished their waiver training. And it was a really sweet experience of them acknowledging these addiction medicine physicians, acknowledging ER physicians in this new identity that they had taken on. We invited, as I mentioned, local media. They came and they wrote a story about it, which was really cool. This was the most powerful intervention we did. Man, if there was only one thing that we could do to make this successful, it'd be this. So we actually found our former patients who struggled with addiction and brought them back. And some of these were patients that our physicians hadn't seen in years and had assumed that the patient had died. But they didn't. They got better. And this strikes at the heart of what makes it special and also hard sometimes to be an ER physician. You don't get to see your successes. The person who you brought back to life 2 weeks ago, who's now back at home eating dinner with their family, is not coming to give you a high five. Similar, the patients who we get into addiction treatment and who get their lives back, they're not coming to pat you on the back. So what you see often is just the negative ramifications of addiction. You see the folks who are overdosing or relapsing, and you begin to create a worldview, this story that you tell yourself that these patients can't get better. And so bringing these patients back disrupted that story because those patients then became extremely valuable. It's like the numerator effect, right? Like these folks now become new schema for how you think about addiction. I'll tell you one quick story. We had one of the patients who came back to talk to the physicians said, look, he's like, I'm glad you guys brought me back, but I have to confess, this is only the second most important thing that I'm going to do this week. And that's because the first most important thing I'm going to do is propose to my girlfriend. And he's, he got his life back. He's, working now. He's back in school. So it just was a really sweet, example of why we get into this in the first place. And then lastly, another salient example, we brought a physician who's actually a primary care physician at our hospital. He himself got addicted to opioids. He lost his practice. He lost his medical license. He was able to get his life back by getting onto buprenorphine. He's now an addiction medicine physician, and he's helping other patients with their stories and their journeys getting back into recovery. And the bottom line is, what we're trying to do here is get someone who is similar, right, to explain to these folks, these physicians, hey, look, this works. You shouldn't be scared of this. I'm like you, and I'm telling you that the way to do this is by getting patients into treatment using medications like we do for any other disease, honestly. We wrote this up. We wrote this up in a journal. I can put that into the chat a little later if folks are interested, or you can go to that site, actually, that page. The NIH picked this story up and basically featured this approach, and we used that to then partner with the state of Texas. They used elements of the original Get Waiver program, except they did it at the state level and basically had like sort of a traveling roadshow of getting people into these addiction treatment, getting into waiver training sessions. And they would host one at every university in the University of Texas system over the year. Wildly successful. This was the second instance. Get Waiver Nebraska was the second state partnership that we did. And then lastly, COVID really took things, COVID created sort of a pivot moment for us. We had this whole model, right? Where we're trying to stuff a room full of physicians, as many people as we can, into one room to get this waiver together. We would get maybe 20 to 25 people max in these trainings. But even that 20 to 25 people was breaking a lot of the local ordinances for how many people you could have in one room, in one space. And so we had to decide, do we stop doing what we're doing? Or is this actually an opportunity to get really creative and take this to a new level? And so we tried to shift our model to doing web-based trainings. And the bottom line is it was so successful. And actually, this is now the way that we do our trainings. So we do these gigantic Zoom courses to get people their waivers. This is our first course, the pilot one in May 2020. This just gives you a sense of the sign-up rate over the course of a month. Got a lot of impressions on our website, a lot of page views, and in summary, about 1,200 people signed up, 850 participated in the course, and then about 527 actually got their waivers. And so the vision is to get to 10,000 waivered clinicians over the course of the next 2 to 3 years, and we're at about 3,200 now. Remember, there was 1% is where we started, right? For ER physicians. What does that mean? That means that when we started, there were 500 ER physicians that had their waiver. When we started, there were 500 ER physicians that had their waiver. And we need to get to 10,000, and we will get to 10,000. Here's the problem, and this is where Ideas 42 comes in. There's a good amount of data that demonstrates that even if you have a waiver, it's actually more likely than not you're not going to regularly use your waiver. This one study found that about 53% of physicians didn't even regularly use their waiver. And so that gets at this concept of the ghost waiver. These are folks who have a waiver but don't actually use it for anything in particular. And so this is a sort of a traditional, action intention gap. And so that is another place where we can leverage behavioral science to close that gap. Look, you went through the hard part of getting a waiver for 8 hours. Now we just got to get you to use it. And so that is where we partnered with Ideas 42 to address this challenge that changing clinician practice is hard. And so for us, there was an opportunity there to develop nudges to quickly create new practice patterns. So the protocol that we created was the following. Number one, any patient that comes in at any time can be started on buprenorphine. We give them a to-go pill pack that has 2 days of medications in it, so they don't have to go to the pharmacy, right? We're removing hassle factors for the patient. They have in their hands 2 days worth of medications, and we have a pharmacist, come and teach them how to use it before they leave. And then every single day, there's walk-in availability at our addiction clinic called the Bridge Clinic, and that's 365 days a year. You guys have been super helpful at trying to sort of create this new approach. We got a big grant to do it. And this is the question that we try to answer together, which is, what are the barriers to physicians adopting this new protocol? How can we get folks to use their waivers that they've just taken an 8-hour course to get? And so we together created a bunch of decision action maps, which are a little bit out of scope to get too far into. But here's what we learned. When we asked physicians, why aren't you using your waiver? You just did this whole course. We've made the protocol really easy. Theoretically, your motivation is high. Why aren't you using this? Here's what we found. There were 4 specific barriers. Number 1, the protocol wasn't easy to remember or access. Number 2, there are lack of cues to initiate conversations about opioid use disorder. Number 3, it wasn't top of mind. It was deprioritized. And then number 4, there was this sort of diffusion of responsibility. And it wasn't clear whose responsibility it was to treat opioid use disorder, because we have psychiatrists in our hospital, we have addiction medicine docs in our hospital, we have social workers in our hospital. And so often it can feel like a distributed buckets problem where it doesn't really fall into anyone's bucket necessarily. And so the ED clinicians feel safe not addressing it. So this is barrier number 1. The protocol wasn't easy to access or remember. Okay, fine. If it's not easy to access or remember it, we're going to make it really easy to access and remember. We created these badge backers, which I still have to this day on my badge. It has the whole protocol right there. And this is, I have to go to work with this ID, so I can't forget this. It's really clear right there. What is this about? How do I do it? So, there's no retrieval process that has to happen. You just look at your badge. And really this barrier, this intervention was trying to leverage ease or addressing the hassle factors to address this barrier. Number 2, people said it wasn't top of mind. It wasn't super salient. And so we created this intervention, which was, I think, one of the most successful ones. And that was that we wrote up success stories and personally shouted people out in their in our hospital, in our department, and called people out by name. Dr. Stuart Harris helped organize the first steps on the road to recovery for a family member of one of our own ED faculty. Thanks to his good work and collaboration with Joe Gustin, this is another provider in our department, the patient was started on buprenorphine that day and is now approaching 3 months in recovery, right? So it's these kinds of very concrete, sticky stories that people remember, and it keeps it top of mind. Next, as I mentioned, it was, folks said it was unclear whose responsibility is to treat opioid use disorder. Okay, the badge says, I treat opioid use disorder. So you can't wear that badge and also be unclear about whose responsibility is to treat opioid use disorder. So this is a really cool little innovation. We made the badge a little wider so that piece hung out on the side and was sort of telegraphing both to the patient and to the providers, hey, I do this. This is my thing. I treat opioid use disorder. And in that case, we were promoting accountability. And then the last piece here, folks said that they had a lack of cues to remember when to address patients who might have opioid use disorder. And so we created an EMR algorithm that was probably the fanciest. Everything else that we did here was very straightforward and effectively either free or very cheap. This one took some time. It looked back in the medical record to see if someone had a high rate or a high risk of developing opioid use disorder. And if they did not have either addiction treatment or did not have an addiction doctor, it would flag this chart by saying, hey, look, doctor, this is the kind of patient you should talk to about opioid addiction. And so this would be this flag was a way of prompting the physician in the moment. And so this is just an example of timely reminders. Listen, these graphs are complicated, but the bottom line is people prescribed more buprenorphine and they got patients into treatment more when you looked at the pre and post intervention. Basically, this one is showing how many patients actually followed up. So it was a higher rate of follow-up at the addiction clinic. And then this graph is demonstrating how many folks, like how many physicians themselves put in the orders for evidence-based addiction treatment. So this one is showing the patient follow-up. So great, a bunch of physicians did things, but did it actually turn into patients following up at the clinic? And the answer is yes, it did, and it was statistically significant. And so, yeah, so we wrote up a bunch of these things, which is really great, and how we're sort of doing the diffusion piece here. We've written a bunch of lay pieces, and shout out to Mitra and Ted for helping to set that up, and have written a bunch of just like scientific publications too about this, because unfortunately that's still the coin of the realm in academic medicine. So that's all I got for you guys. I hope that was interesting. I would love to hear from you if you have questions. I think there might be questions in the chat, but I've definitely not been taking a look. So I'm going to hand it over to Mitra to take us to the next step.
Great. Thank you so much for that presentation on behalf of everyone else, I'm sure. But there are a couple of questions in there. So I'll start with one from Catherine on the Ideas 42 team. Can you talk a little bit more about the recruiting former patients intervention? Specifically, were the patients all those who were in recovery due to taking the Bup?
Great question. Great question. Yeah, so we are really, really lucky to have a tight relationship with our addiction clinic. We meet regularly, probably once every 2 weeks, to discuss cases. And even when we meet, we discuss the success stories that, we have. These folks are a little bit like our children, because it's like some of them, we remember, having this feeling of this person's never going to get better. And then, here it is 4 months later, and like, not only are they better, but they're, now a recovery coach for others. So we had a sort of bullpen of folks that were in our bridge clinic that we were able to, ask. And, this is one of the things that I didn't acknowledge up front, but, we had to be careful about how we framed the ask, because some patients, when you ask them to come and be a sponsor or an ambassador, or to come back and talk to other folks about their story, it can actually destabilize them a little bit. And so we had to sort of be careful around who we made the offer to come back and speak. But yes, in summary, these folks were all in treatment themselves, and so they I don't know if they're necessarily converted messengers, but they're very powerful messengers for the importance of buprenorphine.
Great. We have a question from Anonymous. Are other ERs or primary care practices adopting these provider innovations?
Yeah, good question. Good question. They are not at the rate that I'd like them to, but mostly that is because medicine is incredibly awful when it comes to diffusing innovation. And so, like, a lot of the times we still rely on this, publication or conference abstract model where, like, somebody may read that paper that you wrote and then they use that as an opportunity to try new things. But actually, it's mostly, I think, me giving talks like this that lead to the real innovation and scale, because what often happens is folks will follow up with me and say, hey, can you send us your protocol? And I'll say, of course. And we've got it's all packaged up. We send it to them, and they sort of take it from there. The other thing is, when we do our waiver training sessions, some of these we have thousands. We had 1,000 people sign up for that first course. We've had hundreds of people come through our follow-up courses. And so we, yes, teach them about the waiver and teach them what they need to get their waiver, but we also try and end the conversation off with, you have a new responsibility now. Now that you know how this works, if your department is not doing this, come back to us and we can try and help you get set up. So, so those are the two answers I'd give on that.
Great. And we have a question from Ted at Ideas 42. What would be the behaviorally informed policy to deal with the existence of these waivers in the first place? You know, eliminating the sludge at the state or federal level.
The waiver needs to be removed. You know, I can
Do you,
treat, I can write a prescription for fentanyl. I can't write a prescription for buprenorphine. You know, the medication that is used to treat opioid addiction is harder for a physician to write than the prescriptions that have caused this problem in the first place. Like that's ridiculous. That's absolutely ridiculous. That's still a thing. There was notably some action on this at the tail end of the Trump administration where they actually removed the waiver. They put out, HHS put out an advisory that said that there's been a long time problem. We are going to remove the waiver. And so they did. And then the Biden administration came in. It's still not clear to me what happened, but basically they said, let's slow it all down. Let's put the waiver back in place and we'll reassess. So I don't really know what's going on there, but yeah, we need to get rid of the waiver. Yeah. Okay. So taking it a little bit more, sort of sequenced, you could make an argument that because we're seeing spikes in overdose deaths throughout the country because of COVID, we need to enter into a pilot period where we temporarily remove the waiver for 90 days or for, I don't know, 120 days or something. And we see what happens. You know, we track overdose death rates. We track, rates of, I don't even know what the concern would be. Inappropriate, utilization of buprenorphine, I guess. But, the medication is, you can't really get high off of it. You can't misuse it because it's got Narcan in it. So yeah, long story short, I think, you could enter into sort of a pilot period for, 6 months where you track the rates. And if it works and overdose deaths come down and you don't have inappropriate utilization, then you sort of consider making it more formal and making it permanent. But yeah, I think that would be the way to do it. And by the way, let me just say one other thing on that. We're not the first country to have gone through this, right? Like France had this happen in the early 90s. They had incredibly high overdose deaths rates. They had buprenorphine. Buprenorphine's been around for like 30 years. They also had a law that said you can't prescribe buprenorphine unless you do this extra policy, this extra training. So what did they do in 1994? Overdose deaths rates were high. They had a high barrier to getting buprenorphine. So they removed the barrier, and what happened? Within 1 year, they saw an 80% decrease in the opioid overdose deaths. They no longer have a buprenorphine policy. So, I know we don't often like in this country to model what's happening in Europe. We've got the American exceptionalism thing going on, but I think that kind of is sort of where we're at here. And we ought to take a look at what other countries have done.
There's a couple of questions that are kind of coming up around buprenorphine. And so I'm wondering if you can speak a little bit to, why was there a waiver put in place in the first place? And, are patients dependent on buprenorphine indefinitely? Can you speak a little bit more to that?
Yeah, great question. Why was there a waiver in the first place is a really, really good question, a really complicated one. There's a short answer and a long answer. The long answer, I'll start there first, is that in 1914, we passed something called the Harrison Drug Act, which basically mandated that physicians cannot use a medication to treat addiction, period. So, if you're addicted to this, in the 1900s, it was alcohol. If you were addicted to alcohol, what a doctor would do sometimes is put you on something called laudanum, which is a medication that's effectively morphine. So they were, giving patients this morphine derivative. So they weren't drinking alcohol anymore, but they were starting to get addicted to the opium, to the morphine. So they passed that drug act, right? So now that's still the law of the land. The only reason why we can prescribe buprenorphine is because the waiver exists. The waiver gives you a waiver around that drug law, right? So you almost have to go back to the 1914 Harrison Drug Act and remove that. So that's the long answer. The short answer is there are other examples where medications are used to treat addiction, by the way. So we've gotten around it in other ways. The short answer is there's some serious lobbying going on with, I'm not going to say the names of the medications, but there are some other ways to treat opioid addiction that came out before buprenorphine, and they're very good at lobbying, political decision makers, and protecting their turf. And they have found a way to sort of keep buprenorphine sort of at bay by making it really hard for doctors to prescribe it. In terms of the pharmacology of buprenorphine, so buprenorphine is a partial mu agonist, which basically means that you can't get high off of it. You also can't go into withdrawal. So the way it does that is by binding to the receptors that you've upregulated by using heroin or by using oxycodone. And so buprenorphine locks onto those receptors and shuts them down. So you can't take more heroin or you can't take oxycodone. If you try to, it doesn't work because the buprenorphine is blocking it. So that brings up a very, in some cases, important question, in other cases, a not relevant question. Some people say, like, well, why would you give a medication to try and get somebody off of, get someone out of addiction? And so, I can understand that thought. However, that's what we do. Like, if somebody has diabetes, they need insulin. If somebody has hypertension, they need hydrochlorothiazide, right? So, and by the way, if you're on insulin for diabetes, you're going to probably be on that for a long time, unless you get your act together and you exercise, lose weight, etc. So it's similar to addiction. Really, the patients need to be on the medication for as long as it takes for them to do the harder, long-term, like soul-searching, quite frankly, work around why were you using in the first place. But you can't even be in that mind state if you're bouncing between high and withdrawal and high and withdrawal. You're not in the mental space to think about, how did my past trauma get me to this place where I need to fill this hole with a drug, right? Mm-hmm. It's almost like we need to kind of stabilize you for you to do that work long term, and that's what buprenorphine does.
Great, thank you. So we have a few more questions, and we're coming to the close of the hour. So I actually want to pivot to one question from Jeremy Gunderson, which I think could be pretty interesting for everyone. Are there certain components that you think are more effective than others from your kind of intervention package, or must-haves if resources are limited, particularly in rural ERs that are looking to take up some parts of this kind of intervention?
Great question. It's a tie between two categories of interventions. The first is ease and really making it simple, like really, really simple for someone to do the thing. Literally the way we did many, many interventions with this work. Honestly, the way that I talk about it now with my residents, if they have a patient who needs buprenorphine, I literally just tell them, go to your computer and type the word home into the EMR, the electronic medical record, because when you type that in, it'll bring up the buprenorphine home pack. And literally, so now what do people say? They're like, hey, has he gotten a home kit? Or, are we going to give this patient a home kit? Have you given this person a home kit? So it's gotten to the point now where it's one word is the trigger for, people using this protocol now. So so I think ease is probably is up there in terms of, if you could only do one or two things, what would you do? The second is around salience. And this is particularly important for ER physicians because of what I said. You need to change the narrative of what it means to struggle with opioid addiction for an ER physician, because they don't see their successes. So you create this worldview that these folks don't get better. And so bringing as many stories as you can back to those physicians, and having physicians tell other physicians about their own stories, having patients come back and tell their stories. So I think that those are the two things that I'd recommend as the most helpful interventions.
Great. So we've got time, I think, for one more question, and I'm hoping this is a good one to end it on. This is a question from Piyush at Ideas 42. How did you get interested in behavioral science and using it for this problem?
Yeah, that's a good question. My best friend is Rob Reynolds, and he's an Ideas 42 guy, and so he and I were roommates in Columbia for a little while, Columbia, the country. And we were talking a lot about this. We went to the Kennedy School together, and I learned behavioral science from Todd Rogers, who teaches a class there. And, we were just reflecting on the fact that behavioral science has been used for and I'm not trying to trivialize, but basically has been used for problems that are not as serious as someone dying, living or dying. Will someone vote for this candidate or the other? Will someone buy this thing that they don't really need, right? Using these behavioral science tactics. So we had a lot of conversations around how do you bring behavioral science, these very powerful tactics, not to getting someone elected or getting someone to buy something they may or may not need, but how do you bring it to addressing the problems that patients have? So that's how I got into it.
All right. Well, we have reached the end of our hour. There are a couple of outstanding questions. So I encourage anyone who has questions that didn't get answered, or any more that you think of, please reach out directly to Alister, who has kindly provided his contact information and a way to reduce the hassles involved with contacting him on this screen. So please reach out directly as more questions come to your mind. And with that, want to thank you again, Alister, for your time and for sharing your insights with all of us, and of course for the incredible work that you're doing, both in collaboration with Ideas 42 and not, to try and create some real impact for people who are experiencing some very tough problems, as you just expressed. This is a frontier for applying behavioral science to things that are life and death. So thank you so much. And to all of you who are still with us, thank you for joining us for another edition of the Ideas 42 Academy Seminar Series. We have an ongoing calendar of events of future editions. Please check out ideas42.org/academy for more, and stay tuned.